My name is Anissa Mitchell. I am with PMD Alliance. And today you are joining us for a program that is part of our Proactive Brain Health Alliance educational programs. This program was created to address the concerns of people who are at risk, preclinical or prodromal, experiencing prodromal symptoms, and is done in partnership with our friends from C&D Life Sciences. We wanted to have an opportunity to educate you for those who are kind of in that space where they haven't been diagnosed yet, but may be concerned about diagnosis, may be concerned about general brain health. They may already be experiencing some prodromal symptoms, and that could be like REM sleep behavior disorder, a loss of smell, some depression, anxiety, maybe some mild cognitive changes. And we wanted to give you an opportunity to have education to help you understand a little bit deeper of the things that contributes to neurodegenerative diseases, ways to prevent it, to slow it, to give you an opportunity through education and community to feel like you have somewhere to go. So welcome if this is your first time to this program. We do have a website. I see Julie has already put it up in the chat. So if you open up your chat, you'll see that. You can go to our Proactive Brain Health programs and see our previous recorded programs. We have them quite frequently. We also have another program that we offer quarterly called The Space Between, which is an opportunity for you to come and ask questions of an expert. And then we also now have a support program, a support group for those who would like to join, and that is monthly. And so I'm excited to invite you to those things, and you can find them on that website. So today we have a program that's going to be addressing about lithium. So we have an expert, Dr. Tom Guttuso, who's a professor of neurology and is the co-director of the Movement Disorder Center at the University of Buffalo. He is also someone you would want to follow on YouTube. He actually has his own YouTube channel called Dr. Tom Neurologist, where he reviews up-to-date research on preserving brain health with aging and a focus on potentially preventing and slowing Alzheimer's and Parkinson's disease with low-dose lithium aspartate therapy. And I know we're all interested in slowing aging and wanting to maintain our brain health. Also, we have with us Dr. Padma Mahant. She is a partner with us in the Proactive Brain Health Program, and she's actually going to be addressing your questions at the end. Dr. Mahant is a neurologist. She is specialist in movement disorders and is fellowship trained in movement disorder specialist. She is with the Foothills Neurology in Phoenix, Arizona, and she's also a clinical assistant professor of neurology at the University of Arizona, and part-time is the director of medical affairs at C&D Life Sciences, which is our partner for the Proactive Brain Health Alliance. So if you have questions, please drop them in the chat and she'll be addressing those at the end. I'm thankful to have both of you wonderful experts. And Dr. Guttuso, I'm going to hand this over to you. And you're muted. There you go.
That would help, wouldn't it? Thanks a lot, Anissa. Yes, welcome everybody. Looks like we got 30 people. So yeah, this is a subject that I also want to thank Dr. Mahant for inviting me. We know each other for a long time, way back from University of Rochester. And I love talking about my research. She will tell you that. She falls asleep every single time I talk about it. Hopefully she's not going to fall asleep this time. But I've been very interested in the potential of low-dose lithium therapy for, as you just heard, preventing and slowing Parkinson's disease as well as Alzheimer's disease. And as you'll see towards the end of the talk, brain health in general with aging. I think it does have some very strong potential for those applications. Clearly, there's a lot more research that needs to be done. Let me share my slides here. And this, you can see them? Good. All right. So, yeah, so it's pretty hard to remember everything in a talk. So, if there's parts of this that you're interested in and you want to hear about again, besides listening to this, if you want to get a little more depth into it, there are these little 5-minute videos on this YouTube channel that I started. I mostly started it for patients, so that patients, it's really hard for them to remember and sometimes to comprehend everything in a short, 30-minute office visit. So it's nice at your own leisure to be able to review some of the material. All right. So just to start with some disclosures, I did start this company, E3 Pharmaceuticals, back in 2017. It does manufacture a lithium aspartate dietary supplement. 50% of the profits from this company is devoted to research, which it is challenging to find funding for uh, research on lithium, which is a very old medication slash dietary supplement that pharmaceutical companies are not interested in. I also have current research funding from this foundation in the UK called the Cure Parkinson's Trust. So I'm going to talk about why lithium. Why is lithium worthwhile to study as a neuroprotective therapy to help prevent these diseases and preserve brain health with aging? I'm going to talk about this particular biomarker, which probably a lot of you have never heard of before, and I have it in bold because it is a very important biomarker in neurology in general, but especially in the field of neurodegenerative medicine. When I tell patients that the thing I'm very interested in is lithium's effects on neurofilament light, they're like, what? Neurofilament, what? What is that? But I tell them, oh, the abbreviation is NFL. Everybody can remember NFL, especially here in Buffalo. We're a little crazed with the Buffalo Bills. Neurofilament light really has a lot of potential to help us identify disease modifying therapies, which means therapies that can help prevent neurodegenerative disease as well as slow it down in people who have already been diagnosed. And it also has potential, as you'll see towards the end of the talk, for monitoring brain health with aging. I'm going to talk about a different disease called multiple sclerosis and how treatments, FDA-approved treatments for multiple sclerosis that have dramatically improved the prognosis for MS, how those treatments and their effects on neurofilament light can help guide how we design clinical trials for Parkinson's disease, as well as interpret clinical trials for Parkinson's. And I think this also applies for patients with prodromal disease or at risk. Maybe you have a family history, or you've had a positive skin biopsy, but you're not showing any symptoms, or you have decreased sense of smell, some of the things that you just heard about. I'm going to talk about the clinical trial results that we have found here at University of Buffalo. Research started back in 2019, and I'll go over all the results that we have with a focus on neurofilament light. I was asked to talk a little bit about other vitamins, supplements such as vitamin B1, which is thiamine, vitamin D, CoQ10. Are they effective for Parkinson's? Are they effective for preventing Parkinson's or Alzheimer's? And little spoiler alert is a question mark. The answer is we don't really know. They'll leave this for the questions and the answers at the end of the talk. But a lot of it has to do with the clinical trial design for some of these supplements, and actually problems with the clinical trial design for larger pharmaceutical compounds as well. But anyone interested in asking questions about those particular vitamins and supplements, I'll be glad to answer that at the Q&A. So why lithium? So first of all, what is lithium? Here's the periodic table of elements. It shows all of the elements that make up our planet and all living things on the planet. And you can see number 3 over here, the third element is lithium. So well before lithium was a dietary supplement or a medication, it was part of the earth and part of the universe. It actually was formed about 13 billion years ago during the Big Bang when the universe was established. So it's pretty old. And it wasn't until the late 50s and 60s that it became known to be a highly effective treatment for a psychiatric condition called bipolar disorder, and it's used in much higher doses than what we're using in our patients with Parkinson's disease. But it was FDA approved in 1970. It's still considered the most effective therapy in general for bipolar disorder after all these years. So, in terms of, the topic of today's talk, why would lithium potentially be able to prevent or slow, say, Parkinson's disease? So, this is a figure from a book I wrote in 2023 called The Promise of Lithium. I call it the brain's Bermuda Triangle. Just like ships and planes kind of get lost in the Bermuda Triangle. These are the three main pathological processes, destructive processes that occur in the brain that kind of all conspire to damage and destroy brain cells. In particular, the brain cells we're most interested in are called neurons. And so it's these three processes, sticky proteins that kind of get clogged up and accumulate inside neurons. The main sticky protein that's relevant for Parkinson's disease is called alpha-synuclein. There's other proteins as well that are involved, but that's the main one. In Alzheimer's disease, it's called tau, but actually there's alpha-synuclein in Alzheimer's disease as well. So sticky proteins are one. Another is inflammation, chronic inflammation, and oxidative stress. And you can see the double-headed arrows going in between these three stars. Each one can trigger the other. So it's kind of like this vicious circle. Regardless of how a disease starts, it can trigger these other problems. And this is why people get Parkinson's disease or Alzheimer's disease, is because these processes kill enough brain cells that symptoms appear. We diagnose Parkinson's disease with motor symptoms of tremor, stiffness, and slowness. Alzheimer's is with cognitive problems. But really, in both conditions, and in most of our neurodegenerative diseases, these are really important destructive processes that we need to target and we need to quell if we want to protect neurons over time. So this is really the goal. How are we going to target these three processes? And it's just, you can kind of take a guess. Lithium, it targets all three. Lithium suppresses these cells in the brain called microglia and astrocytes, which are the main brain cells that are responsible for neural inflammation. And by suppressing their activation, it suppresses neural inflammation. Lithium reduces oxidative stress. It also enhances this process called autophagy, which is kind of like the garbage cleaning mechanism of the cell. And so it helps to gobble up these sticky proteins. And by enhancing autophagy, it reduces the accumulation of these proteins. It also improves energy function within the cell by increasing the biogenesis and function of these energy-producing organelles within cells called mitochondria. So that's all fine and good. It's hitting all three of these processes. That means it's got some potential to maybe help with brain aging and prevent these diseases that nobody wants. But these are all these studies, they're done in like petri dishes, cell cultures, animal models. We have been disappointed many times, in particular in the field of Parkinson's disease, with a lot of therapies that have looked great in cell cultures and animal models and have just failed when they get to clinical trials. And so what's really important is, well, what about in humans? Are there any data on lithium in humans that would support a neuroprotective / disease modifying effect? And the answer is yes. And we start with observational data. So this is kind of looking at big populations of people and just observing behaviors and observing maybe medications that they're taking and then following them to see what diseases they develop or do not develop. And it's kind of a strange place where the story starts, but it starts with one of the worst things that any of us can do for our health: smoke. These are actually the packs of cigarettes that I purchased in order to test them for something. Um, but a very strange thing was first observed back in this was one of the first reports in 1959. This is when we were first starting to understand how bad smoking was for our health. And so this is the mortality rates of all these different diseases, how likely it is to die from lung cancer if you're a smoker, or emphysema, or heart disease. And you can see these huge increases, like almost a tenfold increase of dying from lung cancer, threefold for emphysema, heart disease, 60% increase. This is really strange. This condition here, paralysis agitans, there's a decreased risk of dying from paralysis agitans, 64% decreased risk. And this paper from 1959 never mentioned this at all. There was no discussion on this, I'm sure, very unexpected finding. They probably thought it was a fluke, and that's why they didn't talk about it. This has to be a mistake. How could there be a decreased risk of dying from paralysis agitans? Maybe you're asking yourself, what the heck is paralysis agitans? That's the old name for Parkinson's disease. Um, this is the first report, 1959, that smoking was associated with decreased risk for dying from Parkinson's. This is far from the only report. There's been many, many reports across many populations across the world. There was just another paper published in Neurology a few weeks ago. Again, all of them have pretty much every single one has shown at least a 50% reduced risk for developing Parkinson's disease. This is a pooled analysis from 2007. And really, the best studies to try and look for a reliable association are called cohort studies, where you follow prospectively a large patient population over time. And so these are people who are smokers that did not have Parkinson's disease, and you look in the future to see how many develop it. And there is a 77%, this 0.23, is a 77% reduced risk of Parkinson's disease in current smokers. There's even a reduced risk in former smokers and ever smokers. These are significant reduced risks. So the question is, why? How can something so horrible for our health be leading to such a large and consistent reduced risk for developing Parkinson's disease? Obviously, a thought is maybe there's something neuroprotective in tobacco. And one of the first things people thought about when they thought about tobacco was nicotine. And nicotine actually had some benefit in animal models of Parkinson's disease. And the Michael J. Fox Foundation funded a pretty big study, randomly assigning patients with early Parkinson's disease to either a nicotine patch or a placebo patch, and followed them for a year. And after a year, the patients on nicotine were doing significantly worse than the patients on placebo. So a lot of people interpreted that these observational data on smoking and Parkinson's disease must be wrong. If nicotine failed, then these smoking studies must be leading us down the wrong path. But you have to understand there's hundreds, maybe thousands of compounds in tobacco, any one or combination of which could be responsible for the reduced risk of Parkinson's. The Michael J. Fox study showed us it's not nicotine. So you probably see where this is heading. This paper that came out of a group in India in 1980, I was just like Googling, what foods maybe have high amounts of lithium. And I found this paper showing lithium content, and these Charlie seeds, which are black-eyed peas, had the highest concentration of lithium at 0.65 micrograms per gram out of all the foods that they tested, foods and spices. But fortunately, they also tested tobacco. And there was a very high concentration of lithium in tobacco, 18-fold higher than black-eyed peas. And so this is when I really got excited about lithium's potential to prevent and slow Parkinson's disease. This had been something that, still most people really don't understand. In fact, that paper that I just mentioned a couple weeks ago never mentioned that perhaps lithium could be a neuroprotective compound in tobacco. So it's going to take a while, I think, for the public to understand that this is a potential. We actually took those cigarettes that I showed you in that picture and we measured the lithium concentrations and published this in 2019. And it was even higher concentrations we found in these Western cigarettes. I wanted to make sure that, popular brands in Western cultures have just as high lithium content as the Indian cigarettes. And that is what we found, maybe even a little bit higher. And so I'm going to talk a lot about dosing. That's a question I get certainly from patients and from a lot of people is, if lithium is neuroprotective, if it could prevent me from getting Alzheimer's or Parkinson's, what's the best dose? So many clinical trials have failed because the wrong dose is studied. And this gives us a little clue, at least for prevention, of what may be an effective dose. A pack per day smoker, if you just calculate the weight of a cigarette, a pack per day smoker would be absorbing about zero point 0.3 to zero point 0.5 milligrams of lithium a day, assuming all of the inhaled lithium actually got absorbed into the bloodstream. That's a pretty small amount of lithium. Something else that's important, I think, to recognize is that smokers, most people who become chronic smokers, they start smoking when they're like 18 or 17, and they smoke every day for a long time. The average age of diagnosis for Parkinson's disease is about 60, maybe 62. So, you know, this dose might only be relevant for preventing Parkinson's disease if you started taking zero point 0.5 milligrams of lithium a day when you're, 18 or 20. Most 18 and 20-year-olds aren't really thinking about Parkinson's disease. They got a lot of other things on their mind. Um, so why lithium? Let's talk about some other observational data. And so this is in patients with bipolar disorder. I mentioned bipolar disorder is the only FDA-approved indication for lithium use. And so bipolar disorder patients take somewhere around 300 milligrams, maybe 350, sometimes 400 milligrams of lithium a day in order to have a therapeutic benefit to improve. So the old name for bipolar disorder is manic depression. So in order to stabilize mood and prevent these ups and downs of mania and depression, usually that's about the dose that's required, somewhere around 300 milligrams. And what's interesting is that if you just look at bipolar disorder patients who receive lithium, there is about a 60 to 70% reduced risk of dementia and Alzheimer's disease compared to bipolar disorder patients taking other mood stabilizers who are not receiving lithium. So now we've got a much bigger dose to consider, 300 milligrams a day. Now let's swing the pendulum in the other direction. Lithium, as I showed you from that study from the group in India, it's in a lot of our foods. It seems like legumes have some of the highest concentrations of lithium, like chickpeas, black beans, black-eyed peas. But lithium is in most of our food and in most of our drinking water as well. Because it's in the earth, it's in the dirt, and it gets absorbed in our food and plants, and it will then leach into the water supply or drinking water supply. And so this group in Denmark looked at the municipalities that had the highest concentrations of lithium in the drinking water, and they found significantly reduced rates of dementia and Alzheimer's disease in the populations with the highest lithium levels in the drinking water compared to the lowest levels. And if you look at the estimated lithium dosage of people in the areas with the highest levels of lithium in the drinking water, they'd only be getting 0.06 milligrams of lithium a day. So we saw from the previous slide in cigarettes, maybe 0.5 milligrams a day, then 300 milligrams a day for bipolar disorder, 0.06. We need to be able to narrow down the dose before we would consider, what are we going to study in a clinical trial? In terms of, and there's biomarker evidence that bipolar disorder patients receiving lithium have improved brain structure. So these are like imaging outcomes, better white matter integrity, increased cortical volume, and increased hippocampal volume, which is part of the brain real important for short-term memory processing that is one of the first places to generate an Alzheimer's disease. So we've got lots of observational data, more for preventing dementia and Alzheimer's disease than Parkinson's. But what about clinical trials? So that's really kind of where the rubber meets the road, where we take, a patient population, let's say patients with Parkinson's disease, and we assign them to take a therapy and we follow them over time. The best clinical trials, the kind that doctors rely on to guide their clinical decision making and their recommendations, and certainly the best type of clinical trials that the FDA relies on when they're evaluating therapy for FDA approval are called randomized control trials, where you randomly assign patients to either a treatment or a placebo, and you follow them over time, and you look for certain important outcomes. And so there's different types of clinical trials, but this is their most solid evidence, and this is where a lot of our old therapies have failed when we get to clinical trials. So let's start with, most of the clinical trial work that's been done before we started researching it in patients with Parkinson's has been in Alzheimer's disease. And this is the first paper. It was actually a randomized controlled trial in patients with this kind of pre-Alzheimer's condition called amnestic mild cognitive impairment. And it's a randomized controlled trial where 45 patients were randomly assigned to either lithium or to a placebo and followed for a year. And the main outcome measure was cognition, to see if there's any difference in cognitive function between these two groups. I have this circled here because this is really important, and you'll see later in terms of what our research is showing is the best way to think about lithium dosing, which is not a fixed dose, but looking at the serum level of lithium. And that's what this group did. They had a target of a blood lithium level in these patients of 0.25 to 0.5 millimoles per liter. Just for comparison, bipolar disorder patients typically need a level somewhere around 0.6 to 0.8, maybe as high as 1.0 or 1.2, but roughly about twice this amount is required for patients with bipolar disorder. So this is considered low dose lithium. And what they found was, first of all, a decrease in this sticky protein called p-tau, which I mentioned before is a relevant protein for Alzheimer's disease, a statistically significant reduction in the cerebral spinal fluid of p-tau. But also on this cognitive measure, patients receiving lithium, their cognition declined at half the rate of the patients on placebo over 1 year. It didn't quite meet statistical significance. It was a pretty small study, only 45 patients. But in this first study, low dose lithium slowed cognitive decline by 50%. So it's a really good place to start. Another study soon thereafter showed similar results. This study used a fixed dose of lithium of only 0.3 milligrams a day, and you can see these patients on lithium over, what was it, a year and a half, had fairly stable cognition when the patients on placebo had a steady decline in this outcome called MMSE. So, two separate randomized control trials, double-blind, placebo-controlled trials showing significant improvements. This study in cognition, the other study showed a trend towards improvement in cognition, as well as significant improvement in an important biomarker. So, asking these questions, why lithium, what dose, and what should be measured in a Parkinson's disease modifying clinical trial? So in Alzheimer's disease, measuring cognition is kind of a more straightforward clinical trial design, although for Alzheimer's disease, biomarkers are important to assess as well. In Parkinson's disease, things get more challenging. And I'm going to show you an example here of why we need to beware of only measuring motor symptoms. So I mentioned early on, the way that we diagnose Parkinson's disease is on motor symptoms, tremor, stiffness, and slowness. And that's how medications have been FDA approved over the years, is do they improve these motor symptoms compared to placebo? So that's for symptomatic therapy. When we're talking about trying to slow down the disease and improve patients' long-term prognosis, we can be tricked if we just look at motor symptoms. So here's an example of a GLP-1 agonist. So this exenatide is from the same category of medications as probably medications a lot of you have heard about, Ozempic, Zepbound, Wegovy, that are hugely popular now for weight loss. They originally were developed for treating diabetes, and they have a lot of neuroprotective actions. So this is a study published in 2017, and this MDS-UPDRS Part 3 motor score, this is the motor symptoms of Parkinson's. It's a standardized physical exam test that are involved with a lot of Parkinson's clinical trials. So this red line is the placebo group, and the blue line is the exenatide group. And a decrease in the UPDRS score is an improvement in motor symptoms and signs. And, this looks fantastic, right? Just at 12 weeks, there's this huge improvement in patients on exenatide and a little bit of a worsening in patients on placebo. And this improvement, continued, stabilized over 48 weeks. This particular clinical trial had a washout period for these 12 weeks where everybody stopped therapy. And, people got worse, which is kind of what you'd expect, right? If you stop an effective therapy, people are going to get worse. Every single one of these points was statistically significant. And yet, when we go to try and interpret the results of this study, you can interpret this that exenatide unexpectedly is simply having symptomatic benefit, kind of like all the treatments we already have for Parkinson's disease, like levodopa or dopamine agonists and many others. We'd expect to see a big reduction in UPDRS within 3 months and then stabilize. And then if you stop the therapy, symptoms are going to get worse. So what this really screams at here, all this work and all the funding that went into conducting this trial. And at the end of it, you'd say, wow, this study's a huge success, but it's not, because we're kind of handcuffed on interpreting it. It's really difficult to interpret our clinical trial results and distinguish, is this a disease-modifying effect? Meaning, is it protecting brain cells from dying and protecting a person's long-term prognosis, improving their prognosis? Or is it just a Band-Aid, a symptomatic benefit like all the therapies we have right now? And so what this screams is that we need a biomarker. And so getting back to this Bermuda Triangle, this is the goal. We want to quell these destructive processes in order to prevent this. We don't want brain cell / neuronal damage or death. This is what we want to focus on. This is what we would love to be able to measure in a clinical trial to see, is our therapy decreasing brain cell damage and brain cell death? It would be great if it also improved symptoms, but we've got plenty of therapies that improve symptoms. We want to slow neuronal degeneration. That's how we're going to improve a person's prognosis, help prevent the long-term dreaded sequelae of Parkinson's disease, which are dementia and a lot of gait and balance problems and falls. These are the things that, lead to a lot of disability and reduce quality of life. So wouldn't it be nice if we had an objective test that would assess brain cell damage and death? Well, guess what? We do. And it's called neurofilament light. So neurofilament light, so this is a picture of a neuron, a brain cell, and this long projection here is the axon. And the axon is one of the first parts of a neuron that degenerates when it's under attack. That's this lightning bolt, whether it's inflammation or ischemia or aging or sticky proteins or oxidative stress. The axon tends to be the area of the neuron that starts to break down first. And this is just a blow up of the inside of the axon. And these yellow kind of train tracks are called microtubules. These are all structural proteins. And these gray bars are the neurofilaments. And the little tiny gray bars are neurofilament light. And because it's a small protein, it works its way out of the axon. And then a small amount makes it into the bloodstream. And just with a peripheral blood draw out of your arm, we can measure concentration of neurofilament light. And it turns out that this is quite important. We've seen in Parkinson's disease that serum neurofilament light is elevated when you compare it to healthy controls. It increases over time more rapidly. Patients who do have higher levels of neurofilament light have more rapid progression of motor and cognitive symptoms. So the higher your NFL at baseline is a prediction for a more rapid progression of symptoms and a worse prognosis. And then as neurofilament light levels increase, that correlates. It significantly correlates with worsening motor and cognitive symptoms. And so, because of these factors, neurofilament light is likely a disease progression biomarker in Parkinson's disease that can help identify disease modifying therapies. This is a huge benefit for clinical trial design because it kind of cuts to the chase. It lets us measure exactly what we want to improve: brain cell damage and brain cell death. Um, and this is just one recent example of how important neurofilament light is. Um, Many in the research community have understood for a long time that neurofilament light is very important, not only for neurodegenerative disease like Parkinson's and Alzheimer's. In 2023, the FDA approved the first therapy, disease-modifying therapy for ALS, which is Lou Gehrig's disease, kind of a more rare genetic form, SOD1 ALS. And this is the FDA's quote, based on a reduction in plasma NFL that they say is reasonably likely to predict benefit. So even before they saw clinical benefit, they approved this therapy for use in patients simply based on a significant reduction in plasma neurofilament light. So regulatory agencies also understand how important NFL is for identifying disease-modifying therapies. And so a question to ask is, how much NFL reduction do you need to potentially reflect a meaningful slowing in Parkinson's progression, and then also perhaps a meaningful protection in people at risk for developing Parkinson's? Is reducing neurofilament light by 1%, is that enough? Do you have to reduce it by 10%, 20%? How much? What's the magnitude that's most likely to lead to disease modification? And in Parkinson's disease, there's really no benchmark. We don't have either any FDA-approved disease-modifying therapies or any therapy that's been shown to reduce serum neurofilament light. So in Parkinson's disease, we're kind of flying blind. We need to look at other diseases that do have FDA-approved disease-modifying therapies. And the disease that we have the most approved disease-modifying therapies is multiple sclerosis, which clearly is a different disease than Parkinson's disease. It does share that there's progressive death of neuron over time that it correlates with worsening symptoms. But we now have about 15, maybe 17 different disease-modifying therapies for multiple sclerosis. The first one approved in 1993. And really, MS is a completely different disease in terms of prognosis today than it was like 20 years ago. It's just a vastly improved prognosis. So there's two main categories of MS. So all of the FDA-approved disease-modifying therapies significantly reduce neurofilament light, and there's a correlation between the magnitude of reduction and the magnitude of improved protection against disability. The type of MS that most closely resembles Parkinson's disease What happened here? Did I lose you guys? Am I still live?
Nope, we see you well. Everything's still functioning.
Oh, the heck, I lost my slides. You can still see the slides?
Yep.
Okay. Um, good. Well, that's good news. Oh, good. I got them back. The type of MS that most closely resembles Parkinson's is this type called primary progressive MS or PPMS, just in terms of it's slow neurodegeneration that occurs in PPMS. So if we're going to look at trying to assess the magnitude of NFL reduction that could predict what we would want for Parkinson's, we should look at PPMS. And this is the only therapy that's been FDA approved for PPMS. And you can see there's a 12.4% reduction in neurofilament light at week 24, and that led to a significant slowing of disability. This investigational drug called vidofludimus calcium, a greater reduction in neurofilament light, and also an improvement in slowing of disability. So this probably will be the second FDA-approved therapy for PPMS. But this therapy, at least at week 48, only had a 9% reduction and did not slow disability. So we can say roughly, if we're going to just come up with a ballpark estimation of how much reduction in neurofilament light would we want to see in a potential disease modifying therapy for Parkinson's, probably we're going to need to see around a 12% or greater reduction. That would represent a promising disease modifying therapy in Parkinson's disease. So we still have a big range to look at for what dose to use. But in terms of what we should focus on, biomarkers are really important for us to focus on for disease modifying trials. And based on everything I just presented, serum neurofilament light would certainly be an outstanding biomarker to help identify disease modifying therapies in early stage small clinical trials, which is where everything starts. Everything is going to start small. So to review our clinical trial results, we started in 2019 in our first trial. We enrolled 19 Parkinson's patients with Parkinson's disease. Our second trial started in 23, and we enrolled 17 more. Patients combined between these two studies either received lithium carbonate, which is prescription lithium, at about 125 milligrams a day. So again, about half the dose that's used for bipolar disorder, a little bit less than half, or lithium aspartate, which is the dietary supplement form of lithium at a fixed dose of 45 milligrams, 15 milligrams, or some patients receive no lithium. And we assess for 24 weeks. In terms of side effects, 4 patients reported sleepiness, 1 nausea, and 1 had an increase in dyskinesias, some extra accessory movements. So our analysis was post hoc analysis. At the start of all of our research, we weren't really focusing on neurofilament light, and we weren't really focusing on dividing patients in terms of their serum levels of lithium. It was more this fixed dose, 125 milligrams, 45, 15. But when we looked at the results, and especially when we looked at the neurofilament light results, among the 28 patients that we had serum samples on at baseline and at 24 weeks, we saw something pretty interesting. That when we divided the patients up based on their serum lithium levels, among these 28 patients, we found something pretty interesting. And so these are our results. So the high lithium group, which had a serum level of about 0.32, had a 12.8% reduction in serum neurofilament light. The medium lithium group, which had a serum lithium level of 0.17, had a 2% reduction, while the low lithium group that had undetectable lithium levels in their bloodstream had an 11% increase in neurofilament light after 24 weeks of lithium therapy. So this is a 24% swing, comparative swing from the low dose group to the high group. And remember what I said before, we were looking for at least a 12.4% relative reduction in neurofilament light compared to the control group. And this small study, post hoc analysis, we're seeing a 24% reduction in neurofilament light, relative reduction in neurofilament light. So let's That's quite promising. This is the figure that shows the same results, and it shows the statistics that these differences are statistically significant. The p-value, which is how we determine if there's a statistically significant difference, typically needs to be less than 0.05. And you can see when you compare the high group to the low group, the p-value is much less than 0.05. And there's a significant difference between the medium group and the high group. There's not a significant difference between the medium group and the low group. That p-value was just a trend at 0.09. So what can we say about this? We can say that this is a very promising first step. I think that's a safe thing to say. In this post hoc analysis, in a small number of patients, only 28 patients, a serum level of 0.32 was associated with a significant reduction in serum neurofilament light and a magnitude that could be could reflect disease modification. And this is a novel finding. No other therapy has been shown or associated with a decrease in neurofilament light. Lithium is the first. And actually, our paper just was we published it as a preprint, and it just was accepted as a peer-reviewed publication. And then, like I mentioned before, we received some additional funding to enroll an additional 20 patients. And we also started an extension study where these patients then, after the first 24 weeks, can enter a second 24 weeks where we titrate their lithium dose to try and get them in these ranges of serum lithium levels that appear to be most effective for decreasing serum neurofilament light. We'll have our complete data set this summer. And our plan would be, if all of this goes well, to then apply for a multi-center trial, enrolling a lot more patients, prospectively randomized controlled trial where patients are randomly assigned to one or two different doses of lithium or placebo, followed for 1 to 2 years. And the clinical outcomes would be other important outcomes: quality of life, cognition, gait and balance, activity level, as well as motor scores, and then obviously biomarkers like neurofilament light. So I'm just going to finish with this slide, and then we'll open it up for Q&A. Hopefully I didn't ramble on for too long here. So this figure is pretty interesting. Something I didn't mention before, but you can see clearly, is that neurofilament light levels, so it naturally increases as we age. So each one of these little purple dots is a separate person. These are all healthy people without Parkinson's or Alzheimer's. And you can see at 20 years old, neurofilament light levels are pretty low. And by 40, they're still pretty low, but they've actually doubled from 20 to 40. And from 40 to 60, they've doubled again. But you can see somewhere around age 55 or so, the neurofilament light starts going up at a faster rate. And right around age 65, it really starts shooting up, like very quickly. And like we reviewed, neurofilament light, we know, is an objective test that is reflecting neuronal damage and death. So this is showing us that with natural aging, normal aging, there is quite a bit of neurodegeneration that's going on. And for a long time, we've thought that this is just normal aging. Grandma and grandpa are getting old. They're 75, they're 85. Of course, they're using a cane. Of course, they're using a walker. Of course, they're a little confused from time to time and forgetful and will repeat stories over and over again. This is just a figure showing it's almost the same for men too, but this particular paper didn't combine men and women together. So this is just showing you women. So at age 65 to 69, looks like about 14% of people are using a mobility device. That's a cane, a walker, a wheelchair, a scooter, something. About 15%. And you can see this just keeps on going up and up. And use of mobility device is a very good measure for gait stability. And the slowing that we consider as part of normal aging, slowed gait, less balance, need to use a cane or a walker, fall sometimes, as well as slowing of cognition. These are things that we know are associated with elevated neurofilament light. The higher an elevation in neurofilament light level is associated with a more rapid decline in cognition and gait function, as well as higher risk for Alzheimer's, dementia, and Parkinson's disease. So I'll just kind of leave you with this final thought, which is, wouldn't it be nice if we had a therapy that could keep neurofilament light levels maybe like this? Hopefully you can see my cursor. Can you see my cursor here, Alyssa? Good. Um, yeah, I mean, if starting a therapy around 45 or 50 years old or 55 years old, to try and prevent this huge rapid increase in neurofilament light that's reflecting neurodegeneration as we age. And if we could do that, wouldn't it be nice if we could also keep this use of mobility devices like this instead of like this, and also be likely to improve cognition as we age? So it's getting back to, the title of this talk. Could it help with brain health as we age? And, these are the very early days of the lithium story and its effect on neurofilament light. It's way too early to be able to make any kind of determinations on these, what would potentially be huge improvements in public health. But starting with neurofilament light, I think, is a great way to identify meaningful therapies to continue to invest in research. So that's about it. Thanks a lot.
Thanks so much, Dr. Guttuso, and thanks, Anissa and the PMDA and PBHA team for putting this together. I'll go ahead and there's, I think, maybe just a couple, maybe one question in the chat. The question is regarding if people in the study had, it says freezing of air, but I'm not sure, maybe they mean freezing of gait in your clinical trial with lithium. I
No.
think what that's referring to.
Yeah, probably freezing of air. That's a tough one to freeze air. Freezing of gait. No, nobody had freezing of gait. So all the patients enrolled in our studies, almost all had Parkinson's for less than 4 years. And the reason we focused on patients with more early Parkinson's disease is a combination of that's what our early results were showing, is that we were seeing the biggest improvement in biomarkers in patients early in the disease, but also because we're kind of thinking about what would be the end game here, what would be a clinical trial design that would most likely be used to help prove that lithium is a disease-modifying therapy. And that would be in early diagnosed patients. That's when you're most likely to see long-term benefit, is you try to catch the disease as early as possible, when there's been as little amount of neuronal damage of what to protect. It's unlikely that lithium is giving birth to new brain cells. The name of the game here is protecting the ones that are still viable.
Any pointers about, I wanted to ask you quickly about whether you monitor lithium levels and NFL in your patients. And there's a question also about taking lithium with Lexapro and then also folks who have kidney disease.
Yes. So in my patients who are receiving lithium, yes, I'm definitely monitoring lithium levels. It's very important to monitor lithium levels to keep people within that range. Lithium can certainly be very dangerous. If the levels get too high, people will definitely get a lot of side effects. First, sleepiness, dizziness, nausea, balance issues, but very high levels of lithium can be lethal, cardiotoxicities, and a lot of other problems. So you certainly don't want to try and dose lithium yourself. Like the supplements, they're all available as 5 milligram or 10 milligram capsules. And so you don't want to be taking more than 10 milligrams of a dietary supplement of lithium a day unless you talk to your doctor about it and have your doctor monitor lithium levels. Monitoring NFL is a little more tricky. Neurofilament light is now offered by some of the big commercial laboratories like Quest and LabCorp. I've got some concerns about the accuracy of their assays. The company that kind of really pioneered and perfected the neurofilament light assay is a company called Quanterix. They're out of Boston. And their technology is really what's used by all the major research groups across the world. For the longest time, they only offered their technology to research groups, but just recently they started a commercial division called Lucent Diagnostics. So yeah, our group in Buffalo is just starting to get established with Lucent, get an account with them, so we can start monitoring NFL levels in our patients with Parkinson's disease. And hopefully, insurance will cover the neurofilament light assay. So the other question is with other medications. So lithium does have drug-drug interactions, and low dose lithium. So the serum levels that we are finding are associated with the greatest reductions in neurofilament light in Parkinson's disease. First of all, are well tolerated. Patients in general are not having problematic side effects. Some do have sleepiness or nausea, and sometimes we do need to decrease the dose a little bit, but in general, it's pretty well tolerated. And there's been several studies, long-term studies, looking at low-dose lithium effects on kidney function and thyroid function. So lithium can cause kidney dysfunction and thyroid dysfunction, but when it's used in low doses, that does not appear to be the case. The one cohort followed an elderly cohort for up to 4 years, and there was no significant change in kidney function or thyroid function when using low-dose lithium. So in that kind of target serum range that we're studying in Parkinson's. Was that all the questions? Did I miss one?
No, I think you got them. And just in terms of, it's interesting that study, the Denmark study with the lower incidence of Alzheimer's. Was it just Alzheimer's or Parkinson's as well? Was it just Alzheimer's?
It was all-cause dementia and Alzheimer's disease. They didn't assess Parkinson's.
Right. So it's interesting the water table effects in terms of, if there's increased lithium. So I just wonder if there's anything like that that's been looked at here in the US, because we know here in the Southwest, we're fine, Arizona, Utah, maybe even Nevada, that we're okay here as far as lithium levels, but elsewhere, maybe not so much. So do you know anything about those studies? And of course, there are confounding variables like air pollution. We've got a ton of that. So, maybe that cancels out any benefit from lithium in the water, or pesticides, runoff in water. Maybe that might, sort of cancel out any potential benefit. But do you know of any studies that have looked at that specifically in the US?
I think there is one in the US. I know there's one in Japan. That showed similar findings, and I think there is one in the US, but the study that I'm thinking about the most is one that was published within the past year in JAMA, looking at something that really blew my mind, which again, this is just observational study looking at lithium levels across and drinking water across the country on cancer incidence. And the paper was like amazing, the decreased incidence of all cancers that they looked at. It was breast, prostate, colorectal cancer, blood cancers, brain cancer. It was a really dramatic decrease incidence of cancer in the parts of the country that had the highest levels of lithium in the drinking water. And in the Southwest, which, like you mentioned, have the highest levels, there was a 99% decreased incidence of all these different cancers. And there was a nice correlation between levels of lithium in the drinking water and cancer incidence. But in terms of dementia and Alzheimer's disease, I believe there is one in the US, but I can't tell you for sure.
Have to stay tuned. Maybe we'll bring you back for another session, one of our uh, space between sessions where we have more of a free-form discussion. That would be great if you want to come back and talk to us some more. And then we can get to the other sort of potential preventive vitamins and things that we should be taking a look at, like B12 and thiamine, things like that, that are worth, I think, following just for general brain health, especially if you have a specific restrictive diet. I think that's helpful to kind of think about too. So maybe we'll have you come back and we'll have a conversation on that. But I wanted to thank everyone for your attention, and just remember that on the website, the PBHA website, we will have a recording of this wonderful discussion. Dr. Guttuso's book and YouTube channel are linked here as well, and that will certainly provide you with more information on, I think, what really is what we've learned today, the promise of lithium. There's more to do, more to study, of course, but I think it's really interesting that, when we're looking at some of these studies where we're trying to harness alpha-synuclein, we're trying to harness amyloid and all these proteins that we think are the cause, and they're not really proving to, be as beneficial as we hope. Maybe there are other possibilities out there that are going to do more for inflammation, oxidative stress, reducing those factors, and maybe that will eventually get us to a place of more prevention down the road. So really interesting. So thanks so much, Dr. Guttuso. Thanks to PMDA, Anissa, and PBHA. And then Anissa, if you want to close out, please feel free.
Yes, thank you to both of you, Dr. Guttuso. This was awesome. I learned a lot. And thank you, Dr. Mahan, for managing all of the questions, and for everyone for joining us. If you didn't capture your information in the chat, you can save your chat. You just click those three little buttons. You can click it and save it. And I know that there's a couple of links, as Dr. Mahan referred us to, that you might want to go back to. So please do. And if you haven't been on a Proactive Brain Health Alliance site, please join us. And all of the things that we are starting to build for everyone through that resource. So thank you. So Dr. Guttuso, thank you so much, and we'll have to ask you to come back again.
Thanks, Adissa. It was fun.
All right. Thanks everyone for joining us. Have a great day. Thanks.
Bye.